All right, welcome to A Growing Concern. We've been hearing a lot lately about the healthcare reform. We've been hearing from both sides, Republicans, Democrats. President Obama's got his plan. Been going back and forth. You know, there's been a lot of talk about obstructionist. There's been a lot of talk about socialized medicine. A lot of terms being thrown around, and the fact that there's 47 million people without health care, and it's crisis conditions. And we've got two folks with us tonight that are going to talk about this. Both doctors, both from Corvallis. And on my immediate right is Paul, what is it?
Hochfeld.
Hochfeld, right. It's spelled Hochfeld, but it's Hochfeld.
Right.
And then Michael?
Huntington.
Huntington, right. And Paul, you're an emergency room doctor? Is that what I read on the website?
I've been an emergency doctor for 30 years in Corvallis. Mm-hmm. It's been the same job. Sort of fine line between a rut and a groove.
Well put. And you're on radio?
Radiation oncologist. Retired 3 years ago, and I had worked in Corvallis for 22 years before that.
Mm-hmm. Is this pressing for universal health care, which is what this show is going to be about? Is that something new, or you've been doing this for a while?
I started out as an emergency doctor, and I started doing some video things a few years ago, just sort of for fun. And increasingly my job was kind of driving me crazy. Just the number of tests we do that are marginally necessary, and hearing people's stories about how they can't get in to see a doctor and they don't have insurance. And instead of quitting my job, I couldn't do that because I needed health insurance.
I can understand that.
I decided to channel that energy and make a video about what's wrong with our healthcare system, and at the time it was just an exploration for me. I didn't go into this project with some idea that I was going to make a video about single payer or advocating for single payer, but I took books out of the library and read the books and read the internet and followed links to people and found people that I thought knew what they were saying and had looked at this a lot longer than myself, and put together a video about why healthcare is so sick in this country.
And that's the one we're going to be playing some pieces from in a little while,
yes.
A couple 4-minute clips. Well, it occurs to me while you were talking that you're on the ground level in an emergency room, and you're a specialist then.
Right.
And what have you been seeing out there that's led you to believe this?
Well, in my field, using radiation therapy to treat cancer patients, we were using increasingly complex, expensive methods. And as a result, between 1996 and 2006, we increased the cost of treating, say, prostate cancer from $24,000 to $66,000. And yet I don't think anybody could show that our results were anywhere near that much improvement to account for that expense. During that same period of time, the family insurance premiums doubled. So somebody who was just barely able to afford their insurance premiums in 1996, in a few years could no longer afford that and stopped seeing doctors. And then we in the cancer center would start seeing patients 3 years out from a neglected illness, a cancer that might have been detected early, but they couldn't see a doctor, or they didn't have the money or the insurance to do so. Then we would see them with an advanced, basically untreatable cancer, and now we would pour our hundreds of thousands of dollars trying to rescue that situation. Mm-hmm. And it started working on my conscience, and I felt I need to do something about this soon. And I decided as soon as I retired, I would fight tooth and nail to change this system.
Mm-hmm. I see. Well, what you were talking about there leads me right into, maybe we could do your little PowerPoint right now. You can kind of give expand upon what you were talking about.
Yes.
And they can just bring that up on the switcher there whenever you're ready. Is this the first?
This is the first slide.
All right. Oh, there we are. Oh, it comes out nice.
This is probably the most important slide, and what you see on the top is a blue line representing the average family income, total family income, between 1996 and 2025, slowly increasing. The red line at the bottom, rapidly increasing, is total family insurance premiums. The two lines intersect in the year 2025. Obviously, that's not going to happen. The system will fall apart. Private health insurance will disappear long before that. Mm-hmm. We need to do something soon to get rid of private health insurance.
Right. And you can just go to the next slide from here, and then he can bring it up, or you can do that live, either one. Well, we have the next one up there.
You know, we can't simply blame insurance companies per se. They do take the existence of insurance companies costs the Americans 30% of our tax dollar, or the money, goes for administration. No business can stay alive spending that much on overhead. And one of the problems of the fragmentation that accompanies these multiple insurance companies and multiple plans and eligibilities is that it's so fragmented we cannot gain efficiencies from any savings that we do get. And there's one very good example that the audience can see here. Virginia Mason knew they were doing too many CT scans. And this is a hospital in Seattle, and they decided they would accept only those conditions that met the American College of Radiology standards. Not just a headache, but some neurologic symptoms go along with it. They were successful. They reduced their CTs by a significant percentage. Now in a closed system like Kaiser or the VA, that manager for that department would have been promoted and rewarded. This manager nearly got fired, and you can probably guess why.
Because the revenues went down.
Revenues went down. They had to fire people. No benefit could come from that tremendous savings.
Except the benefit to the people.
Right.
That were having to put the money out.
Right.
I would argue that it didn't even benefit the people, it benefited the insurance companies that were paying for the CAT scans.
Mm-hmm.
Mm-hmm. Right.
Right. Well, that's just one example, I imagine,
Right.
of many.
Many examples where you can't recapture efficiencies. This shows the example of the cost tripling in my field in a matter of 10 years, but the same thing has been happening in cardiology, orthopedics, urology, doubling and tripling the cost of treatments without being able to show that there's a proportional benefit. So we have to ask ourselves, what could we have done with that extra $44,000 that we've been pouring into every prostate cancer patient? Perhaps training people to take care of their diabetes better, avoiding hospitalizations, avoiding amputations, avoiding strokes for people that have hypertension. So there's that dilemma there, and then there's this family on the right that no longer can afford their health insurance. Actually, this family still has a high deductible plan, but the father there feels he cannot afford the deductible to go see his doctor about his back pain and still pay his insurance premiums, so he doesn't go in. Mm-hmm. So then someday he gets sick and we have to rescue yet another person who's been neglected.
Mm-hmm. So that 47 million people without health care is really just the tip of the iceberg.
That's right. So in addition to that, there are another, maybe an equal number of people that are underinsured like this family.
Mm-hmm.
And the tragedy of it all is that we are paying for most of the health care through our taxes, through Medicare, Medicaid, public employees, and the tax subsidies that employers get for offering health insurance. We should be in charge of the policy. Instead, we're allowing vested interest and lobbyists to sit in Congress as we speak, determining how our money should be used.
This 60% that you see in this pie chart here that is the taxpayer portion of the total health care bill is doesn't reflect the whole picture. And the whole picture is that insurance premiums that individuals and businesses are paying are inflated by about 15%, maybe even more, because charges are increased. Hospitals charge more, doctors charge more because of all the people that don't pay. So that
right.
the insurance premiums we pay and employers pay are inflated by that much to cover the cost of the uninsured, which is kind of a bit of a hidden health tax, isn't it?
I would think so.
So that we're, the bottom line is we're all taking care of everybody anyway, but we're not acting like it.
And it seems to me that the higher these bills go, the more people can't pay them. So it's just a feedback on itself.
Right, they call that cost shifting.
Yeah, yeah. I see. That's a good point to bring up because statistics, you know, there's usually, you could dig deeper and deeper into statistics and bring out more information. And just on the surface, this says a lot, but what you bring up really brings it into focus even more.
And since we're all paying for everybody anyway, when an individual that we won't take care of for their chronic problem, their diabetes or their hypertension, if they get sick because we've not been willing to pony up the small amount of money to help them manage their chronic disease, when they get ill and they show up in my emergency room, it's not only morally the right thing to do, but it's the law that I have to take care of them. And when they end up in our ICU at great expense to our hospital and they can't pay the bill, guess who pays for it? We do.
We do. You know, I was thinking about that on the way in today, that they say the thing for the physician is first do no harm. So the way this thing is set up, everybody's harmed. You know, the taxpayers, the doctors who have to do this when they don't want to necessarily, and of course the people that have the problems, everybody's being harmed by it.
So unnecessary suffering, unnecessary cost.
And if you see that it's mostly taxpayer dollars, and a hidden tax because of the cost shifting, there's actually nobody in this healthcare factory that we've got, this $2.5 trillion healthcare factory, that's responsible for asking the question, how do we, the taxpayers, get the most health for our healthcare dollars? There's nobody that's responsible for even asking the question, let alone answering it.
And they do ask that in other countries, I understand, because we get a lot less for our money than other countries do.
I would point out in France, they take a view that if you have one of these chronic illnesses, whether it's cancer, diabetes, hypertension, asthma, you do not have to pay the first dollar to go in to see your doctor. They don't want any barriers for patients with chronic illness between them and health care. And by doing that, they keep people healthy and out of the emergency room and out of the intensive care unit. Fewer amputations, fewer strokes. They're very clever and smart about this. We take the other approach. We aren't going to pay for that person who doesn't deserve this care until there's a tragedy.
You know, I've been active in like forest issues and a lot of different issues, and one of the free trade, they always say people before profits, but you know, that's perfect for this as well. I mean, you know, they're putting profits before people, and that's basically in a nutshell what's going on here.
But one could characterize what's going on in Washington right now. This is a little bit of a jump to where we're probably going to go later, but that all of this healthcare debate in Washington right now is largely dictated by the insurance or the healthcare industry that's pouring $1.6 million a day into lobbying. And what all that money is intended to do is to manipulate public policy so we continue to have a healthcare non-system, so to speak, that's good for corporate profits instead of a system that's good for public health and public good.
So that explains why you get the Republicans that stand up and saying that the Canadian system kills people and all the different things that are going on, when actually our system kills people a whole lot more.
Yeah. There's always an easy case to find of a waiting line in Canada or Great Britain, but at the same time ignoring the 22,000 people that die each year because they don't have health care. Each one would be a soap opera drama tragedy that needs to be exposed, not these occasional cases that they pick up from countries that have good systems.
When people say that we've got the best healthcare system in the world, most of us in the know will roll our eyes. And it is true, probably, that if you have a serious illness and if you have insurance in this country, and you get access because of that to the very best of the very best, you do better than maybe somebody in another country. But if you think of it as the forest and the trees phenomenon, that we're taking really good care of individual trees that happen to have good insurance, and we're not only taking good care of them, but we're taking more care of them than we need to. we're actually pouring more resources into them than we need to take care of their illnesses because of what Mike was saying about, you know, an extra $40,000 without good results. So individual trees in the forest are actually being taken care of pretty well, but it's using resources that need to be used to keep the forest healthy. So that the forest is actually suffering for the trees that are getting more care than they need because they have insurance.
Sure, and I think what comes to mind are some of our celebrities that have beaten back cancer, and you know the 400 or 500 of our representatives that have the best, legislators have the best health care in the world. You know, they get the best. They're the individual trees you're talking about, but the forest, which is the rest of the people who have these deductibles and all that, it's not working out for them as well.
Right.
Maybe we can play the clip.
I was thinking that myself.
I think the second one, the one about it's a political problem.
All right, yeah, we kind of switched away on the director in there. You wanted to play that it's a political problem, which is towards the end of the menu there. Hopefully we'll get that.
And what he's going to talk about towards the end of this little clip is that the cost of health care is actually hurting us on many different levels. That our government, our state government and our federal government are having to spend a lot of money on health care, more than as much as total in other countries on total health care. And that money that they're spending on health care, which is an entitlement, is competing with investments in education and infrastructure,
social services,
and the environment. And one can easily make an argument that if you look at the health of the community, that those other investments are probably have a bigger return than the investment in an individual being able to see a doctor.
Okay. All right, I think we're ready.
To do this is going to take, I believe, a political answer. I do not believe that this system will in some way self-correct, that you will see Medicare change because costs have gotten too high, that you'll see commercial insurance change because premiums are too high. I don't think that'll happen. You'll see a growing number of people who don't have health insurance. You'll see them flood our emergency rooms. It will drive costs in state government to the point that we can't fund other needed programs such as education, public safety, in the judiciary. Uncontrolled healthcare costs are now driving most state budgets.
Our healthcare system is sick because it costs too much. Some think we can save as much as 25% by adopting a single-payer system. We can save substantially with substantive malpractice reform. There are clearly some savings to be found with better coordination of care, avoiding duplication of services, and making fewer mistakes, all of which can be achieved by adopting a national electronic medical record. In addition, we can save by disallowing the mass marketing of prescription drugs and educating the public about end-of-life issues. Finally, we can find dramatic savings and get better results by paying our primary care providers adequately to do the preventive care we really need. Our healthcare system is a bizarre blend of the worst of capitalism and the worst of socialism. It isn't a system at all. We need to get over our fear of the government and embrace the idea that in healthcare, somebody needs to be in charge so we can keep our eye on the prize, which is health, not profits.
In poll after poll, the majority of American physicians say the national health insurance system would provide the best care for the American population for a fixed amount of money. We need Congress to start listening to the American people who want and need national health insurance and to stop listening to the private health insurance industry and the drug industry who are saying, don't do it.
I don't think we need more money in the system. You know, if money was equated with health, we'd have the best health population statistics in the world, and we're down right around Cuba right now.
Look to the historical track record of healthcare systems that work. The European systems have worked. They've held down costs. They're popular with the citizens.
Access is necessary, is important, but it depends on controlling costs, and you're never going to control the costs until you have a good, workable, single-payer system.
Congress, right now, you think that you can serve the pharmaceutical industry and the private health insurance industry, and the voters won't notice. But the one thing you need more than the money that these industries pour into your political campaigns is votes. And God help you if you ever find that the votes are going in one direction and the money in another. I think then you'll have to go with the votes. So really, it's up to the public, and I do think the public is starting to understand what's going on.
All right.
People,
Right, we're back. That was a good little clip, and there was actually the clip right before this one we might get to in a little while too. But time runs away when it's pretty fast. We've already got, you know, only 40 minutes left, 37 minutes. But you've got a graphic up here that was pertinent to what they were talking about as well.
Right. So all of this money we've been talking about pouring into the medical care and all that we're debating in Congress, primarily devoted to this 10% of this pie, and it is sucking money out of the other areas that determine our health: education, infrastructure, housing, food, and research on environment and genetics. So we need to stop pouring all of our resources into this one little piece of pie.
Right, there it is. So you got all those are the environmental, genetic, social, lifestyle and behavior, and medical. Mm-hmm. So what you're saying is that medical doesn't necessarily even need to be that high in order to do it right?
That's right, yeah.
This whole, what I learned in making my video, I think more than anything else, is that it's all about cost. That right now Congress is focused on access and financing. And Obama's really trying to focus on cost, but the industry, it's just the powers that be are just really keeping them from going there. And the reason, I think that our difficulties with universal access exist because it costs too much. Mm-hmm. If we're cheaper, we'd be able to accomplish universal access. So when we look at how are we going to fix our healthcare system, what we're really asking is how are we going to get more health for our bucks? How are we going to make it less expensive? Mm-hmm. And I would contend that until we first find savings in the system to cover the cost of everybody immediately, and then have systems in place to control costs, we're never going to get to true universal access. And Obama pretty much said that the other night during his speech, Wednesday night. Mm-hmm. He said that if you want true universal access, you're not going to get there without single payer. And then he realized, I think, what he said, and he moved on really quickly. Oops, I shouldn't say that. Yeah. So we really, and the low-hanging fruit for controlling costs is the insurance companies. They add 20 to 30% to total cost without adding anything to health.
Administration.
It's just, and it's not just about getting rid of the insurance companies, though. It's about getting rid of the insurance companies to find those immediate savings, and then once you have a single risk pool, one insurance company, and that insurance company knows that it's responsible for maximizing health for its budget, then you've got a system, because there's somebody that can make these other difficult decisions about where we're going to invest our money and how we're going to not waste our money on things that are of marginal benefit. And that's really what Mike was talking about earlier, is that we spend an awful lot of money on things that are of marginal benefit when we could be spending them on things that really produce health.
Yeah. One thing that really struck me towards that video, when it had those lists and then it changed the list from one to what could be done in its place, is how deep this issue is. But when you go to Washington, those folks stand up and they talk about, oh, this people are going to get killed, or it's socialism, and all these really superficial things that they're not arguing about what's really on the ground, what we're talking about here. They're arguing about really superficialities. Mm-hmm. And I think that the American public are smart enough to grasp what we're talking about.
I think so. Yeah.
I'd like to think so.
I'd like to think so. But then that's not, the lobbyists are responsible for keeping it on that level, though, I think, because they want to use these gut reactions because they can manipulate people that way.
They're using fear. Mm-hmm. So, for some reason, we would rather that the insurance companies ration health care for profits instead of the government making difficult decisions in the name of social justice on how we're going to use these precious limited resources to produce the most health. I keep coming back to that.
I'd like to point out that we have to think of not a disjointed or a distant government pouring these decisions or directing these decisions. We have to be an active part of the government that makes these decisions. We may someday have capital budgets for a county or several counties, and elected officials have to be responsible for organizing the method in which we decide how money will be used. And this is the way it's done in Canada and Sweden and so forth. The doctors and the administrators, the pharmacists and consumers sit around a table and decide how will this money that we're allotted be used. So it's not a distant government, somebody telling us, it's us. We have to take the initiative to be part of government.
Sure, and it's that way whether you're talking about national forests or trade or any of it. You know, the people, the reason why we're there is because people have not been involved in their government here as much. And I see you have another slide up here.
Yes, this just is showing more of the waste, sort of quantifies it. These researchers, one of whom you just saw speak, show that 31% of our healthcare dollars are spent just in fighting over payments, administering the healthcare dollars. No business can stay alive with a 31% overhead. So that's one thing that needs to change.
I love this graph.
This is a little bit more explanation of why that administrative cost is so high. Between 1970 and 2000, you can see the growth of two segments of the healthcare force. The yellow one that's easy to see is the growth in numbers of administrators. These are clerks and CEOs, middle managers that have been employed to manage this battle over payments. And then that little thin orange line at the bottom represents the increase in total number of physicians. In Canada, a doctor might need one person to help out in the clinic and to do a half-hour billing in the evening. That family practitioner in this country may need 4 or 5 people to do that.
It's interesting you say that, because part of what the lobbyists or the puppets in Washington are parroting from the lobbyists is that you don't want the government to be there because you'll have a bureaucrat between you and your doctor. Well, that's what they have right now, apparently.
I was showing my video, Health, Money, and Fear, to a group of true peers, emergency physicians, and I at the beginning when I first started talking, I said, I hope there are some people out there that really challenge me because I'm tired of preaching to the choir. And they all just nodded their head and agreed that, yeah, we got a broken system and it's nuts. But the interesting thing was there was an insurance billing guy. This is, as an emergency physician, we hire a billing company to do our billing for us and our collections for us, and that way we can make a lot of money and not feel like our hands are dirty, I suppose. But it's just the way it works. And this guy was one of the worked for the billing company. And he said, you know what? I would much rather fight with a government employee than with the insurance companies. And if it was a single-payer system and I lost my job, I think it would be okay. I'll find something else to do. But he realizes that the amount of effort and time that it takes to get money from an insurance company dwarfs how easy it is working with the government.
You know, we've just going along. We've mentioned some of the things that have been said. That they're wondering about. But I was watching Ed Schultz today, and he says that they're going to end up trying to get whatever they get through by what was it that I said that was that they're going to call it a cooperative or something like that. Now, what is that all about? Because I've been hearing that, but it's not defined in my mind, and I'm sure other people feel that way as well.
I feel that I don't know enough to answer. One example that the Heritage Foundation used in a publication I brought is the Group Health Cooperative in Seattle, which is kind of like a Kaiser, but they went on to explain why it wasn't the true kind of cooperative, because the patients are not partial owners of the insurance company.
Right.
That's as much as I've learned about. What I know, though, is that it still is talking simply about moving money around to pay for insurance coverage. The whole article from the Heritage Foundation does not talk about delivering health to us, to citizens. It's how are we going to arrange coverage, and when you talk in that manner, you omit the fact that many people can't afford to even get into that coverage. So I doubt that it's going to amount to anything.
I can't speak with authority about cooperatives, but if we step back a little bit and look at healthcare, and we look at it right from the beginning, which is with medical education and our distribution of physician supply, what's happening today is we're losing primary care doctors by the droves. They're being driven out of business because of the hassles of being a primary care doctor. Primary care doctor makes half of what a dermatologist makes in income, a third as much as some of the other specialists. And so we're losing primary care providers. And if we had a and you need primary care doctors to deliver health care efficiently. Every place it's ever been looked, both domestically and internationally, the more primary care doctors you have, the better the outcomes, by whatever criteria you want to use, longevity, infant mortality, and the cheaper it costs. More primary care doctors, better outcomes, cheaper cost. We're down to 30% primary care doctors in this country, and it's going down rapidly. Other countries are at 50% or 60%. So that we're not going to have a cost-effective system here until we actually start to reverse that trend of we have to pay primary care doctors more relative to the specialists, but we can't just pour more money into the system, so they're going to have to come closer together. How do we do that with a system that's chaos, with all these different payers? There's no handles on it.
It can't be done.
And that's why I say that getting rid of the insurance companies is not just about the savings of getting rid of the insurance. It's about having a system so that we can do something about our distribution of physicians.
That had never occurred to me, that that aspect of it, but that sounds like it's bottom line one of the most important.
Definitely.
Care is extremely fragmented, and end-of-life care is something that people don't really want to talk about, but we spend an awful lot of money in this country keeping people alive to suffer longer. And the fragmentation of care, the absence of a primary care doctor who's following that patient along, means that when these decisions are being made towards the end of life, that they're being made by specialists. And a specialist gets paid a lot of money to do an intervention and doesn't get paid much money at all, literally, to sit down with the family and the patient and say, why, if you were my mother, I would not do this aortic valve replacement at age 90 because it's likely to cause you more suffering. And when we talk, I could go on and on about end-of-life care, but it's not about rationing stuff at the end of life. It's about paying physicians to have these difficult, time-consuming, and awkward discussions with people that aren't happening right now. I think if people were fully informed at the end of life, as they would be if their primary care doctor were following them through this process,
as they were aging, right?
That people would make better decisions. Their quality of life would be better in the last 6 months, and it wouldn't be so expensive. Medicare spends 25 or 30% of all Medicare dollars in any given year are spent on people that die that year.
That's pretty high. So, well, you mentioned that there was a clip from this video before the one that we played that was a good one as well, that was pertinent to what we were talking about. Is that still something we could...
I think why don't we go to the one that addresses the mirror of, is healthcare a mirror?
Is healthcare okay?
And we have a for-profit healthcare system. This $2.5 trillion factory that I'm talking about is what's in this factory are a bunch of economic entities that are trying to make a buck. And the way you make a buck, the way you make the most bucks in this factory is you invoke technology to keep sick people from getting sicker. And you don't get paid to help people. And it's all about profits. And so I think, and profits don't work in healthcare like they work in widgets and plasma TVs.
Why? What is the difference?
Well, if we can play that clip.
Oh, okay.
That would be,
clip will tell us. Have
Yeah.
they found that yet? I think they probably got that ready to go.
There it is.
That's the one.
It's the question of whether the ills of our healthcare system reflect our society. Definitely, yes. When you compare for example, the American healthcare system with the Canadian healthcare system, you see a reflection of two different kinds of society with different values. The Canadians believe in cooperation, and they believe that their society has a responsibility for the welfare of the individual. We don't believe in equality as much as we believe in opportunity. The inequality of distribution of wealth is not important if it reflects the fact that some people work hard and deserve to get what they've earned. Health care can't be dealt with that way because anybody can get sick, whether they're rich or poor, and it can be a disaster. It can destroy your life, destroy your family, destroy your resources, take everything away from you.
The healthcare system does in part reflect the values of this community, or perhaps we might almost say non-community. That is the lack of concern of each for the other.
We are an individualistic, commercially oriented culture. One president said the business of America is business. And if you go back to American history, we were individualists. Thomas Jefferson, the less government is better government. So you've got this long historical thread that makes us where we are.
The reason that this show is being produced and I'm sitting here being interviewed is, a basic assumption that the way our healthcare system is not a reflection of society's values, that this is not the healthcare system that society wants. It's one that is a result of history, political obstacles, greed is the one that we've gotten now. And I think there are a lot of people very eager and who think they can improve it and to better reflect society's values.
I don't believe that Americans are born as greedy cowboys who don't care about the community and whose aim in life is to be richer than anyone else. That happens to many Americans because they're bathed in that ideology. We don't have education that's guaranteed as far as you can go. We don't have health care that is guaranteed. We don't have a secure old age. So the kinds of things that other countries do, we're left kind of naked. We're left vulnerable. And I think that that drives a lot of Americans to think that they cannot accumulate too much. That one serious illness, one tuition check for Harvard, old age, one broken hip could wipe them out. And so they've just got to stash away as much as they possibly can. They not only want to stash away as much as they can for themselves, but for their children and their grandchildren too. It looks like just unbridled greed, but I think it's partly something else too. I think for some people it is unbridled greed, but I think for many people it's fear.
Our system.
All right.
That was the wrong clip again,
But it fit right into what we're talking about.
That's what happens when you take an emergency doctor out of the emergency room, where all that nurses are there to keep me from making mistakes.
Well, I see that Mike's got a graph up here that is talking about dentists, which is something we haven't touched on yet.
Nope. I'm sorry. This is the denial management industry. And it has to go with some of that 31%.
Oh, denial, I see, yeah.
Some of that 31% overhead. So you can see from this, between 2000 and 2006, a rapid growth of an industry, $80 million effort to help physicians claim the payments that they thought were due for the services they rendered. And so this is just to help the providers get the money they thought they should get for their procedures. On the other side of the fence, you'll see probably an equal amount of money spent by the insurers to try to make sure that those payments are not made.
These are, I've been told, and I don't know this as authority, but it's very believable, that the same software designers that are selling software to providers, doctors and clinics, to make it more likely that their claims are going to be accepted, are selling the anti-missiles. They're selling the missiles, and then they're selling the anti-missiles to the insurance industry to fight the software that's it's nuts.
I don't doubt it. Just like our government sells, weapons to both sides in a lot of conflicts across the world. That's how it's done. So what this is saying then is there's an industry for denial management.
Yes.
This $2.5 trillion healthcare factory with 10 floors, the top 2 floors are people fighting over money that don't contribute anything to the profit, that don't contribute anything to what's supposed to be the product, which is health.
Which is health, right.
Instead of profits.
Boy, that just kind of kicks me back. I mean, obviously, if you stop and think about it, that has to be what's going on to some degree. But if it becomes an industry, like our prisons have become an industry, it really says, does this really reflect who we are? It was well put.
It gets even worse than that. The AMA, which arguably only represents 20% of physicians right now, actually own the coding numbers.
I was going to bring that up. I'm glad you did. The coding numbers.
When doctors and clinics and hospitals want to get paid, they have to, for every submission of a bill to an insurance company, they have to use a diagnosis code and a procedure code. Either you sew up a laceration, or you do a level of evaluation, or you do an appendectomy. But it's based on code numbers called CPT codes. Turns out that the AMA owns the proprietary rights to CPT codes, so nobody can publish any books that list these codes without giving the AMA royalties. So the AMA gets $70 million a year licensing these CPT codes to people. And you think the AMA wants to change things? I don't think so.
And you say they change those codes?
Oh yeah, the codes change every year or two. They get updated.
And the committee, the 29-member committee that decides this, is primarily specialists. I think there's probably 4 family practitioners or primary care physicians. At least they are underrepresented. So CPTs still greatly favor procedures rather than outcomes or cognitive care.
Mike's talking about what you can actually get paid for these procedure codes or these evaluation codes. That it's the fee schedule that determines this big gap in income between primary care providers and specialists.
Yeah, it sure gets complicated quick. You said we still got like 15 minutes. You said that there was one more clip you wanted to play. We can bring the menu up.
Bring the menu up. So this time
we'll take a stab in the dark here. It won't take a stab in the dark.
Need a nurse to help me.
Because these are all great clips. Play chapters.
Play chapters.
Here we go.
The culture of medicine.
Okay, the culture of medicine. There we go. We'll just... This will be the third and final clip. Audio up.
That occur now. Because in my day, drugs for treating mental illness had not yet been developed in any large amount. So when I was a young practitioner, there were a few drug companies that found it worthwhile to buy my time. So if I didn't succumb to temptation, part of it was that there was no temptation then.
When I started out in medicine, which is now over 60 years ago, medicine was not viewed as an industry. Nobody called it an industry. Most people thought about medicine as a professional social service, and the name of the game was to provide good health care to everybody. Over the last several decades, things have changed, and we have huge numbers of investors owning and operating insurance companies, medical facilities of all kinds, and they're in it for the money. In 1963, Kenneth Arrow, who later won the Nobel Prize, published an article in which he explained very clearly why health care was not a market like other ordinary commercial markets, and why the laws of supply and demand didn't apply to health care. He points out that medical service is often defined by an illness over which you have no control. It may threaten your life. You may be scared to death. You may be incapable of exercising any judgment at all. You have to depend on the expert, compassionate advice of your doctor. And your doctor, therefore, doesn't act as a vendor. He or she is a professional and is committed to put your interests ahead of his or her own interests, to serve your interests first. That's not the way it is in business. After investor-owned businesses got into the hospital field, apologists for investor-owned health care said, maybe you don't like the sound of it, but we're really more efficient. We really know how to manage organizations, and we're giving consumers, that is patients, we're giving consumers a better deal for the money. Well, it's just baloney. Yes, there was some evidence that at first investor-owned hospitals spent less money because they hired fewer RNs and they cut corners wherever they could. But there was never any evidence that the result was lower charges to consumers, to patients. If you believe that it's good to take money out of the healthcare system and put it into management and to profits and stock dividends, then you can say there's some advantage. But I have the old-fashioned idea that when we spend money for healthcare, we ought to be getting healthcare.
Well, you know, it's good to see compassionate doctors, but I think that we need a few more doctors that are mad as hell. Which, you know, it's kind of a segue to one of the things I wanted to talk about that we hadn't even touched on yet.
We're mad as hell.
We're mad as hell. What I'm most angry about, I think, is the political process in which the industry is manipulating public policy for profits, and that's what I'm really mad about. The healthcare stuff is a little understandable, but I think that the American public, if we can get their attention long enough, can hear a rational argument for why we need a single risk pool, and we need to have somebody asking the question, how are we going to get the most health for healthcare dollars? So
that's what you intend on doing here, starting in September, right?
Right. We are forming a caravan called Mad as Hell Doctors, and we are going to travel from Oregon through the northern half of the United States over a period of 3 weeks. Stay with people, talk with them, learn their stories, and obtain media as much as we can. And then in Washington, D.C., we hope we have a long caravan of cars and vans to demonstrate to our legislators how strongly we feel that they need to free themselves of lobbyists and listen to the people. So we're hoping to light a lot of fires along the way.
And you have someone to help you that's with Dennis Kucinich's?
we have put some of a significant chunk of our own change into phase 1 of this project, which is to hire Dennis Kucinich's 2004 campaign organizer, as well as a professional media creative consultant in Portland here. And unfortunately, politics has been reduced to theater. And
as the news.
Well, that's what we're talking about.
Yeah, right.
And we understand that we need, I'm tired of talking to the choir. And my guess is most of the people that are tuned into this show are probably already part of the choir.
Right.
And so what we need to do is we need to create media events. And so we're going to be doing advanced contact of media and have people on the ground in these communities we're visiting ahead of time to try to create these media events so that we can get some serious media attention on people's default channels of entertainment. because that's the way people get their information these days, is on their default channels of entertainment. And so we're hoping to get their attention long enough to ask the question, well, I wonder what's making these guys so mad. They're doctors, and they don't look like they're like way out there. We're really very mild-mannered, demure doctors.
But you have something to say, and like you say, the choir that may be watching the program, I'm sure they've learned a lot, though, even though they were probably for universal health care. There's still a lot to learn, because this subject is I wouldn't say convoluted, but it's many layers, it's multi-layered, and you both brought in a lot of aspects and components of it that had never crossed my mind before. And with some of these stills that you brought up, you've got another one there that looks like it might be.
I think it's worth just taking a minute to show how insurance companies stay in business only by either excluding risk or decreasing services. This slide demonstrates the excluding risk. So in California, insurers will deny coverage to applicants who have any of these ailments. And you might see things like ear infections, cystitis, allergies, things that we consider part of life. Not only will they deny a new applicant, but a person who happens to have coverage under, say, a Blue Cross in California and gets a serious illness and really needs the coverage, there's a process called rescission. And insurance companies will look for any sign of one of these ailments in a person's history, and if they can find it, they can say, we will not cover this serious illness because you did not tell us about the earache you had in 1966.
So will they keep taking their premiums until they make a claim and then invoke that?
Well, I think they're very generous. I think they might give back the money that they paid for the claims, but they won't cover the $200,000 debt that was incurred by the breast cancer.
So it's like difference will be like night and day. Yeah.
We're running out of time, and
we got about 5 minutes.
Yeah,
here.
so I think it's really important for people to understand some of the subtleties of what's going on in Washington right now. And the question is, should we hurry to pass a health care bill before the August recess, or do we want to slow down?
Right.
And I think we need to slow down. I think we all need to slow.
For different reasons.
For different reasons.
Yeah.
The public plan option that we're talking about is not single payer. It's not the government takeover. The public plan option is really just another insurance company. It's not going to do anything to give us a system in which somebody's in place, and the playing field is not going to be level. That the insurance industry has already written into H.R. 3200, the House bill that's being promulgated right now, rules that will direct the highest risk, the most expensive patients into the public plan. And if the public plan has the more expensive, sicker patients, which they will have because the insurance companies with all their $1.6 million a day are going to design it that way, when that public plan starts to struggle because of the demographics in a few years, and we have to revisit our health care reform because it's not controlling costs, the industry is going to point at the public plan and say, see, it's failing.
It's failing, yeah.
Single payer won't work. And in fact, we never tried single payer. But I think the American public will fall for the millions of dollars that the industry will pour into media ads, as they're doing now, to confuse the public about that. What nobody is proposing, nothing in Congress right now that they're even putting near the table even resembles single payer, except H.R. 676 and then Bernie Sanders' bill, and they're not getting any traction because our legislators think they need industry money more than we think we need a healthcare system that works for us.
So since we've only got about 3 minutes left, would it be better not to have any healthcare reform? Is there anything about that would make it better? I would think it's kind of like damned if you do, damned if you don't.
I think that's possibly true. I'm concerned that if we get the health care reform that it looks like we're going to get now, that in 3 or 4 years, when we have to look at it again because it's not working, that when they blame this single-payer effort, we'll actually be farther from single-payer 3 or 4 years from now than we are today. We will have taken a wrong road. It will have to turn around, and when we turn around, we'll be farther from where we need to be.
So it'll be some short-term gain, but long-term loss then.
Yeah, I think we need to take time. Rather than having a system that fails and is called a failed government system, we need to take a year to think this through. Each month something shows up like the Congressional Budget Office, ORSAC, evaluating Obama's plan, or the government's congressional plan, showed that it was going to cost 1.3 trillion and still leave
10 years or something.
and still leave half of the uninsured population uninsured. That makes everybody sit back and think, maybe we should think a little longer about single payer.
There's this individual mandate. The way they're going to fix health care is they're going to mandate that everybody get insurance. So that's our plan for universal coverage, all right? And so that the insurance companies love that, because now every individual in the United States is forced to buy a commercial product. And, oh, if you can't afford it, well, the government will pay the difference. And that's how we get universal access. That's throwing more money at it. We can't throw more money at it. We have to find savings so we can cover everybody, and then we have to have a system so we can control costs.
And, you know, forcing everybody to have it just plays right into the insurance companies and gives them more power. it seems like.
That's what they want.
So that's what's going on. So, well, we're down to a little over a minute. Well, we could go on and on for another hour. Is there any sound bites you want to leave the viewers with, Mike?
MattisHealthDoctors.com.
There you go.
Yeah.
We need help.
Look us up.
Right, and you can, I encourage folks that are out there, the viewers right now, to get onto that website and contact these folks. And if you have connections in the media, you have connections in other parts of the country. You say you're going, what, Highway 90 then, to the northern part of the state, possibly? And along that way, to kind of pitch in and, put your shoulder to the wheel, like I've talked about before on this program. And this will only be successful if the community responds and helps these good fellows put the word out there, because the opposition have billions of dollars, and they're spending it very lavishly. So I want to thank the crew for doing the great work they've done, and I thank the guests. And also, you can get that video on the internet.
It's on Blip TV. If you just search Health, Money, and Fear, you can find it, or you can contact me from the website, and I basically send videos to whoever wants it. And
all right, that's it. Thanks for tuning in. Good night.